Dr. Williams, it is such a pleasure to have you at the Academy of Citizen Activism.
It is truly an honor and privilege to be here with you today and to be part of this very distinguished panel to discuss how we can move from health disparities to a new health democracy within our society. And I would like to introduce the panelists that we have today, a very distinguished group of individuals. I'm just humbled to be with them and in their presence. I don't have time to give a full introduction of each because it would take a lot of time, but I want to first of all and have you meet Dr. Marcella Alsan. She's a professor of public policy at the Harvard Kennedy School. She is trained in public health from the Harvard T.H. Chan School of Public Health. She is a trained physician from Loyola University, and she has a PhD in economics from Harvard University. And one of the things once we get going, I want to talk about a study that she recently did that has important implications. I use her study in many of the lectures that I give. Our second panelist today, another very distinguished panelist, is Dr. James Hildreth. He is the president and CEO of Meharry Medical College, the nation's largest private, independent, historically Black academic health sciences center. Dr. Hildreth has a PhD in immunology from Oxford University, an MD from Johns Hopkins University, has served on the faculty of Johns Hopkins. He had the distinction of being the first African-American in the 125-year history of Johns Hopkins School of Medicine to earn a full professorship with tenure. And that happened in the basic sciences, and that happened in July in 2005. He also was the dean of the College of Biological Sciences at the University of California, Davis, and he was the first African-American dean at that university, which was founded in 1905. So a number of firsts, very, very distinguished panelists. And then I want you to meet Alden McDonald Jr. Alden McDonald Jr. is the president and CEO of Liberty Bank and Trust Company, one of the top African-American owned financial institutions in the United States. He's widely recognized as a passionate advocate and dynamic catalyst in providing avenues for economic growth, home ownership, wealth building, and leadership development in the African-American communities. And those are issues we want to talk about today. I just want to tell you a little about what he's done. Under his stewardship, the bank, Liberty, has grown from an initial asset base of $2 million to more than $650 million in assets. And finally, last but in no way least, I would like you to meet Allie Young, a citizen of the Diné Navajo Nation, and she comes to us from northern New Mexico. She's a storyteller and a writer, and she is on a mission, yes, a mission to increase authentic representation of Native Americans in American culture, in television, in film, and in mainstream media by sharing stories and traditions of how her people have helped and continue to help them persevere in a world where they are largely invisible. So what a wonderful panel we have today. And I want to tell you what we are trying to do with this panel. We really want to focus. We will talk about the problems, but we want to focus most of our energy on where the solutions lie, where the interventions lie, where are the opportunities to transform communities of color in the United States. We want to have takeaways that activists can take and know what are the next steps and what they can do in terms of moving forward. Now, I want to begin by talking to the physicians on the panel, and I'll talk with Dr. Marcella Aslan first. We are in the midst of a pandemic, the pandemic of COVID-19. It has killed more than 500,000 Americans, adults in the United States. And we know that the death rates from COVID are 3 times higher for Native Americans than they are for white people in this country. And they are twice as high for African Americans, for Latinos, and for Pacific Islanders in this country. So in the midst of this pandemic, one of the things we worry about is access to high quality medical care. And Dr. Aslan, you did a study, a randomized control trial, looking at what difference it makes when Black men are treated by a Black physician. Could you tell us a little bit about your study and what we can learn from that as we move forward in terms of ensuring greater diversity in the healthcare workforce?
Thank you so much, Professor Williams, and thank you for the opportunity to be on this panel. What I learned and why I was interested in this study is because there's obviously COVID-19 has highlighted, underscored the underlying inequality that exists in the United States. And this is an inequality on top of an inequality. If you look at the, deaths across the board, obviously COVID-19 is more lethal for the elderly. But the fact of the matter is, many individuals in the communities you mentioned, Black Americans, Native Americans, don't actually even get the opportunity to reach that eldest old age. And so conditional on age, these gradients are even more stark and have reversed even the minimal progress that we were enjoying up to that point. And so it's a great time to have a conversation about why do those inequalities exist in the first place? And there are lots of different factors. And I know many on this panel, including you, Professor Williams, have looked very hard at some of the social factors, the neighborhood attributes, the lack of access to good paying jobs, the fact that many people in this, many adults in America only have access to insurance if it's through their employer, and interruptions in labor market attachment can disrupt that. So what I looked at, though, was this fact that there is a gap in how often African Americans are accessing preventative care. And this is particularly stark for Black men, who have the lowest life expectancy of any major demographic group in the United States. Again, this was prior to COVID-19. And so we were interested in looking at the difference that it could possibly make if they actually had access to a physician that looked like them, which pretty much many other white Americans enjoy, and even some other groups enjoy, but Black Americans, African American, Hispanic Americans, Native Americans don't have that opportunity. And so what we actually ended up doing was myself and Dr. Owen Garrick and a graduate student, Greg Graziani, out of Berkeley, we ended up setting up a clinic. We had to actually set up a clinic, Professor Williams, because there wasn't a clinic we could find that had more than one Black doctor in it. So we actually had to set up our own clinic so we could actually provide a clinic that had both Black and non-Black physicians available. And we randomly assigned Black male patients. We had, talking about social determinants, we actually had Uber donate ride sharing services because transportation is a huge issue, a huge barrier to care. We paid for the medical care that was provided because cost is a huge barrier to care. But trying to strip all those things away, we actually then randomly assigned the patients to either have a Black or a non-Black male physician. And the results were really surprising. So we looked at first, if we just showed them a tablet, a photo of the doctor they were going to see, would it change the sorts of demand for preventative care, for the flu shot, for blood pressure, for cholesterol screening? And we actually found no difference. But when they actually got to meet the doctor in person, we saw a huge increase in the demand for flu shots, for diabetes screening, for cholesterol screening. And why we did it in that two-stage way was if we just saw differences after someone sees a photo, maybe that is showing you that they have an aversion for one group or a preference for another group. We didn't see any of that. If we only saw differences actually after they had the opportunity to interact with the doctor, which suggests that it's really about better communication and a better match between a doctor who is African American, a Black male doctor, and a Black male patient. And these results were on the order of 50 and 70%, could literally, incredibly reduce the cardiovascular mortality gaps that we're seeing. And they were pretty surprising, even for us, looking at the data.
So that is in fact a striking finding, and it is a truly a challenge for our healthcare system in terms of diversity. If you look at national data for the United States, in the mid-1960s, 2.9% of all physicians in the United States were Black. In 2019, about 5% of physicians are Black, just over 5% are Latino, 0.3% are Native American. So, Dr. Hildreth, we have a long way to go.
Having trouble with the double speaker.
Yes, Dr. Williams, thank you.
We have a long way to go, and I wanted to ask you about your suggestions as a dean of a medical school, and a dean of a medical school that has had a disproportionate impact in producing African-American physicians in this country. What does the medical system need to do so that we can ensure there are more African-American physicians? And let me also mention African-American male physicians. There was a report in 2014 from the Association of American Medical Colleges that there were fewer Black male physicians in the first year or students in the first year of medical school in 2014 than in 1978. So how do we address these problems?
Thank you, Dr. Williams, and thank you for the opportunity to be a part of this very important conversation.
I'm having trouble with a double speaker and back.
Ensure there are more.
Sorry. So the problem is quite profound, and the problem appears to be one of a pipeline, a leaky pipeline, Dr. Williams. And from my perspective, the solution can only begin with improving the K through 12 preparation of children of color. Most of them, as you know, go to schools that are not well equipped or appropriate to prepare them for success in STEM subjects. And of course, to go to medical school, you have to at least be able to have some competency with those things. And I want to point out that from 1908 to 2008, the percent of Black physicians in this country never got above 2.5%. So think about that. For a whole century, we had less than 2.5% Black physicians. And when I started medical school in 1982, there were 550 of us who newly matriculated that year. As you say, if you fast forward to about 30 years, the number actually went down, even though there were 25% more seats available in medical school. And so I think the problem is one of a pipeline, but there's also some implicit bias at work in this. And some people are in denial about this, but I think that there's clearly evidence that when
I'm having sound problems
in medical school, there's an implicit bias against Black men, and that needs to be addressed. And give you one more example, there are 65 schools of dentistry in the country, I believe. One school is responsible for 40% of the Black dentists in this country, even though there are 65 schools of dentistry. And I happen to be the president of the institution that is training 40% of the Black dentists. So what I'm saying is that we have to get the other organizations to do a better job of bringing diversity to their enrollments. There's no other way around this, right? I also think that for a country that spends $17.5 trillion on healthcare every year, which will be the 5th largest economy on the planet, we should be able to fund some of the education of medical doctors to take away the financial challenges. because of course minority students, indigenous students, African American, Hispanic, they do not come from families with the wherewithal to pay for their education. So they come to medical school with a huge amount of debt. So the debt is also an important part of this that needs to be addressed. And I just think that for a country to spend that much money on healthcare, even 5% of that would pay for the education of all the medical students in the country. Think about that. So we have to find ways to better prepare students. And I think we have to do that by showing them that it's possible. So what we're doing at Meharry Medical College is we've adopted some middle schools, and I have my medical students and dental students interacting with those middle school kids to show them that someone who looks like them can actually do this. Because I think seeing is believing, and that's what we're trying to do.
Thank you. Thank you so much, Dr. Hildreth. That's insightful in terms of some of the interventions that have taken place at your medical school. But it is also striking what you said. I was not aware of that statistic, that 40% of the dentists are being trained by Meharry Dental School. And that's amazing. It just shows what could be done if other schools made a commitment to it, and maybe that example needs to be lifted up more by activists, so that we can get other schools to rise to the occasion and to address the challenges we face. Now, I want to go to in a minute Alden McDonald, and one of the things that Dr. Hildreth said that's so important. He said that we can't just look at who is graduating from medical school or who is entering medical school. We have to go all the way back to look at the quality of elementary school education and how are our young people being prepared. One aspect of racism that I have studied is residential segregation and the ways in which where you live and the access to opportunities in your neighborhood shape your entire trajectory of life. There is stunning scientific evidence, some done by Harvard economists like David Cutler, who did publish a paper years ago looking at a national sample of blacks and whites, young people making it in the labor force. And he showed statistically, if you could eliminate residential segregation in the United States, you would essentially erase black-white differences in income, in education, and in unemployment, and reduce black-white differences in single motherhood by 2/3. All of those striking differences are linked to opportunity, linked to place. And I would argue that some of these differences at the local level, at the neighborhood level, is also one of the challenges that Native American communities also face to a large degree in these United States. A more recent study by Rash Chetty that takes an intergenerational lens on the challenge shows, Rash Chetty is another economist at Harvard University. What his work shows is that he asked the intergenerational question. Let's look at black children that are starting out life at the same level of household income as their white counterparts. And let's see how those children are doing in the next generation. So from the parents' point of view, he has taken into account parental income. And he shows that in 99% of census tracts, adjusting for family income, black boys do more poorly than their white counterparts. Why? Is it lack of effort? Is it cultural factors? No, they live in neighborhoods that differ in access to opportunity. So, Dr. Alden McDonald, I'm calling you doctor today. Dr. McDonald, you work in the banking space. You work in terms of providing avenues for economic growth. You have done work in home ownership. You've done work in the financial literacy and wealth building. And I would like to learn from you, what are some of the opportunities you see for addressing neighborhood improvement, enhancing quality of opportunity in the neighborhood. It looks like we are having some technical difficulties, and Alden McDonald was on my screen a minute ago, but he's not there now. So hopefully he will reappear, and then I will ask him that question. in the meantime, while we wait for him to reappear, I will go to Allie Young. You want to address what I would call racism that is deeply embedded in the culture of American society, in terms of how Native Americans and other populations of color are presented. These issues are much more important than people often give them credit for. There's a study by Professor Freiberg and colleagues that shows that exposure to Native American mascots led to declines in self-esteem, in a sense of community worth, and in achievement aspirations for Native American young people. So tell us a little bit about your vision and what are the steps you are taking to address the representation of Native Americans in American culture, and what can other activists who want to make a difference do along these lines?
Yeah. Hello, everyone. Thank you for having me. Yeah, that is important. That's the core of my work. Native Americans are still largely invisible in this country, and it's a problem because we are the first citizens of this country. And I mean, I think there was a Teen Vogue article a few years ago that said the new form of racism against Native Americans is invisibility. And when we're not actively lifting up our Indigenous brothers and sisters, we're part of that. We're part of the perpetuation of that sort of white supremacy. And that stems from whitewashing history and narratives. And it's still happening today. I mean, just yesterday, we came out with this sign-on letter about Rick Santorum and his disparaging remarks about Native Americans, saying that there's not much Native American culture in American culture, and that we didn't contribute much to the founding of this country. And so that was said to the Young America's Foundation, and then he went on to CNN to say that he misspoke, and just no accountability. And we're trying to hold large networks out there like CNN accountable. And so that's the kind of work that I am very much involved in within my own community. I came home about a year ago. During this time last year, the Navajo Nation became the hardest hit community in the country per capita. And during this time that we locked down the nation, and I worked very closely with our president of the Navajo Nation, Jonathan Nez, to start a campaign called Navajo Strong. And in that campaign, it was really to lift up our community, to fall back in a way on our culture, which has always been there for us and kept us alive to this point, and to remember our ancestors and what they fought for, and that deep culture and ceremony and language that is the root of who we are and in our survival. And so during this time, I've been connecting with Native American youth because of those statistics about self-esteem and mental health, and how Native mascots and negative stereotypes of our people are very damaging to the self-esteem and mental health of Native American children. And so a lot of my work is about reconnecting our Native youth to what makes us proud to be Indigenous peoples, and that is rooted in our culture. And I think it's not only for Native American communities. I think it's the same for communities of color across the country. And when our children can connect to their culture and build that foundation, it makes them stronger, because as Dr. Hildreth said, that you cannot be what you cannot see. And I also believe that very much, and that's why I'm always trying to increase the representation of Native peoples across the media. And not only, it was just maybe a month ago that the first Native physicians and medical staff were casted cast on Grey's Anatomy. So we're just now reaching that point in terms of fiction and television where we have Native peoples in these roles, and our young people can look up to these characters and see themselves in that way. And we're going to continue to do that in pop culture, but also in a very foundational way in terms of ceremony, language, and the cultures that are part of who we are in our existence, because all of that is very important, and it only strengthens who we are as and our contribution to this country.
And while we recognize that to address the challenges we face, we need all kinds of upstream structural interventions, I think your work and the work of others is illustrating that we also need to think of the healing that our communities need from the racism and the indignities that we encounter. And I want to mention briefly a study that was done. It's a classic study of Native First Nations, they're called in Canada, communities. At the time, those First Nation communities in Canada had one of the highest rates of youth suicide in the world. And these researchers studied 196 communities. And what they found that although as a group, these communities had the highest rates of youth suicide, half of the communities had no youth suicides at all in the last 5 years. And so the researchers got to saying, now, what is it about those communities that are doing so well in the face of these conditions? And they identified about 8 measures that captured what I would call protests, advocacy, empowerment, and the celebration of their culture. Communities that had lawsuits against the federal government of Canada over the right to manage their resources, whether it was fire or schools or other resources that served their community, that were engaged in advocacy for their community and that engage in a number of strategies of empowerment for their communities, and had a place in their community where their culture was celebrated and young people were taught. And they found a dose-response relationship. Every additional measure of protest, advocacy, and empowerment was associated with a lower level of youth suicide. And it says something powerful, that one of the strategies that we need to address is how do we engage our young people and provide opportunities for them to get involved. I don't know if any of my panelists want to comment on this work and what it tells us about where we need to go in terms of engaging our young people, that giving them reason to believe that the future can be better and there's things that they can fight for. Let me start with Allie, and then I'm going to go to Dr. Hildreth next.
Yeah, absolutely. I think that's exactly right. And, I also come from a community that, the teen suicide rate is high. My own brother took his life when he was 17. Mm-hmm. And so that's why this work is deeply important to me. And I think, when we can engage the youth in that way, and I think it's nowadays, there's just so, the possibility is limitless, and we can there's so many creative, innovative ways that we can engage with Native youth and kind of provide those tools. And I'll just give you an example quickly. When we started this Navajo Strong campaign, we launched what we called the Indian Country Hero Challenge, and I am friends with the Hulk, Mark Ruffalo, and we pulled him in, and he was very happy to help. But we launched that Hero Challenge with him, and it was incredible for our youth to see someone like him pay attention to them and know that they exist in his eyes. And when we launched that campaign, calling on Native youth to use TikTok, social media, all kinds of ways to communicate to the world about who we are during this time, especially at home in intergenerational households, where we have the time to reconnect to some of our elders, to learn our language and songs. So we encourage them to post that on social media, and it started that Navajo Strong campaign. And we saw just a big boom of Native TikToks, which is ongoing now. You can easily Google Native TikToks and it'll take you down a rabbit hole, but it's very fun.
That's wonderful. I want to welcome back Alden McDonald has made it back to us. But before I go to him with my question, I want to go to Dr. Hildreth, because we're talking about what we need to do to affirm our youth and our young people. And Dr. Hildreth, you are the president of one of the HBCUs, the Health Sciences Center. But I've looked at research on historically Black colleges and universities, and what the studies have done, that although only about 20% of like in college, African-American students in college are at HBCUs. African-American students who go to HBCUs are more likely to complete their undergraduate degree, and they are more likely to go on to higher education. And one of my professors when I was in graduate school, Dr. Walter Allen, was studying the fact that their mental health and their sense of psychological well-being is better. What is the secret sauce that HBCUs use to ensure even greater academic success for students who sometimes, if you just look at standardized test scores, they are not as strong as some of the students who are going to the historically white institutions, but they outperform them in life, professionally, and so on. So tell us what's the secret sauce of HBCUs and what we can learn from that as we move forward.
So Dr. Williams, it's not really a secret. We create an environment where students feel affirmed. They feel supported, they feel valued. I like to say that at our institutions, you can bring your whole person to work and to a classroom every day. You don't have to leave part of yourself away from this, right? I like to tell the story that every year at Meharry Medical College and the dental school, we admit students that have been rejected by the predominantly white institutions, all of them, Harvard, Vanderbilt, Stanford, all of them. But by the time we're done with these students, they're being recruited by these same institutions as residents. So they weren't good enough as students, but they're clearly more than good enough as residents. And what it is that, again, we create an environment where students can thrive. And that really means that you feel supported, you feel nurtured, you don't feel different, you don't feel like an imposter. I, throughout my whole career, have been the only Black person sitting in rooms many, many times as a student, as a postdoc, now as a professor. Even in my leadership role, sometimes I'm the only Black person. And sometimes you don't feel like you can be your whole self, right? So the secret is you create an environment where people feel like they can be who they are, free from judgment, fear, or anything like that. And I think that's the secret of why HBCUs are so successful in preparing students for a successful future. And we build on the resilience you develop as a Black person. If you are a minority living in the United States, there's a certain level of resilience you have to have just to have a modicum of success, right? When we were growing up, we were often told, and I'm sure others were told this, you're gonna have to be at least twice as good as the white person. So there was no room for slacking. It just wasn't tolerated, right? And I would sometimes feel like you're almost being punished by the people that you love you, but what they're really doing, they were preparing you for success. And I think what we do at the HBCUs is we create an environment where people feel like they are valued. And I have to say this at least once during this panel. We've heard so many times throughout the last year and a half, leaders who will say when there's an untoward event that this is not who we are, right? I would suggest that after 10 or 12 times of seeing the same kind of phenomenon happening, maybe it is who we are. And until and unless we value all lives the same, nothing's going to change. I don't want to be pessimistic, but I'm just saying, until we affirm that every life matters the same, we're going to have these issues. But I think that we as communities have to build support systems for each other. And that's why I'm so pleased by Mr. McDonald and what he has done, and Allie, what she's doing And Dr. Aslan's study was opened so many eyes. I mean, I celebrated that work because it made the point so very well. And I'm rambling now. I apologize.
No, but that's good. We value the wisdom that you have shared with us. I'm going to turn to economic. Dr. Hildreth, I'm going to come back to you later in the panel, assuming we will have time to talk about distrust in the healthcare system and how that is shaping vaccine hesitancy in populations of color. I want to come back to that, but I want to turn to the economic issues. We talk, Alden, McDonald, you missed it. I even at one point missed and called you Dr. McDonald. But we were talking about the extent to which in the United States, access to opportunity varies at a neighborhood level. Let me, I'm not sure if you heard me, but so I'll give you one other study, a study done by Dr. Dolores Acevedo Garcia from Brandeis. She created a neighborhood opportunity index for children. And what she was able to show, looking at ranking all counties in the United States and census tracts that were large enough on almost over 25 indicators of access to opportunity for children, like quality of schools and the quality of elementary schools and early childhood centers, and the access to safe places to exercise and access to food, and what was the level of exposure to chemical substances, as well as the economic home ownership rates and employment rates and rates of college graduation in communities and so on. And what she shows in the 100 largest metropolitan areas in these United States, 67% of all African-American children are living in a very low or low opportunity neighborhood. That is also true for 58% of all Latino children and over 50% as well of Native American children, compared to 1 in 5 white and Asian children. On the opposite end, if you look at the high opportunity neighborhoods, almost 2/3 of all white children and 2/3 of all Asian children are living in high opportunity neighborhoods, compared to about 1 in 5 of children of color. So the point is, Mr. McDonald, one of the things we need to do is to create opportunity at the neighborhood level. We talked about the importance of that with a pipeline and the quality of elementary schools. You have done work in economic growth, in home ownership, wealth building. Tell us what you have done and what the successes have been, but also what can we learn and what can we do to foster great economic opportunity within disadvantaged communities in this country?
Well, thank you very much, Dr. Williams, and I hope you can hear me okay, and I'm sorry
I can hear you well.
Very good, thank you. I am honored to share with you and share with the group and share with the audience what we do here at the bank, Liberty Bank. We're very proud, first of all, that we're an African-American owned bank. We're the largest African-American owned bank in the country. And by the way, I apologize for the numbers that my staff gave you. We're not 650 anymore. We're $850 million. Very close. But the significance piece is that in looking at the collaboration here, I think it's important to find a way to bring the African-American banks into the mix. Community development, financial industries into the mix, because what we do validates the figures that you gave just a few minutes ago on the results of healthy living. Over the last 20 years, our little bank, and I call our little bank because at one point we were 650 million not too long ago. Over the last 20 years, we made over 10,000 home loans. And so the home loans that we make, for the most part, represents people who would normally be turned down. So the economics into the healthcare system and collaborations, in my opinion, is very healthy and should be focused. I'll give you a couple of other back points. I've been involved in the healthcare industry by being on boards, working with physicians, working with neighborhood clinics for the last 45 years. And there are a lot of discrepancies in the industry for the business at hand, whether it's clinics, whether it's the pharmaceutical needs, the equipment needs, et cetera. So what if this collaboration can bring the financial institutions into the healthcare disparities and issues and find different ways of bringing it to the forefront? My wife and I and Liberty Bank, we for example, put together and funded a diabetes clinic at the local hospital in our community because of the statistics. 1 out of 4 African Americans have some form of diabetes. So the point is, in bringing the financial leadership in, and what we do as executives in the community can play a very, very important point. But we need to be informed. You need to educate us as to how we could close these disparity gaps in the healthcare system for the African American and the brown community. I think we can bring a lot of solutions to the table. Why not look at teaming and coming up with a collaboration between the financial institutions and large corporations? Because why can't we fund perhaps daycare centers, early childhood education, and build those facilities? Why can't we build, for example, having people in the medical industry start a business where we could begin looking at collaboration of early childhood and healthcare needs and the financial needs of all of these communities? I think the collaboration can do some of these things, and I would like to challenge everyone on this call of working together, because if we can put some economic development in with the healthcare needs, we can do a number of things. We can create jobs. We could give a better place to live. We could be very informed and have say in policy making with government entities. Whether it's HUD, why not come up with a new program to assist individuals with income levels of X and living conditions of Y, funded through the financial institutions as well as the medical community. So we could partner in coming up with solutions for the disparity in healthcare in our community. Now, I had a lot more to say, but I apologize for the for the problems that we had, the audio problems, and
we apologize that you had challenges. But before I let you end this, we'll come back to you later. But I want you to talk a little bit about the work that your bank is doing around the issue of financial literacy in the community. Could you tell us a little about that?
Yes,
the importance of that.
Yes, the financial literacy we feel is very important because we don't have the financial literacy in the schools. We have worked for the last 5 years trying to get financial literacy to be placed on the national level with the national education programs. So in looking at that and looking at today and looking at why we have a wealth gap, is because we don't know very much about the finances of the world. My father was a waiter, and my mother was sewing for extra money. We lived in a rent house. We did not have these conversations. So the wealth gap has been, for most African Americans, pretty much in the background, in the forefront. That's where it should be. So on the financial literacy piece, we need to put that up front, in front of everyone on the education stage, as well as the wealth building stage. Now, in our financial institution, we do a lot of one-on-one for financial literacy, not only in groups with schools, not only with groups in the community, but when someone comes in with a financial issue, we do one-on-one counseling of helping them do consolidations. Consolidations will then permit someone to have a better quality of life, to be able to have more discretionary income. So the financial literacy piece, not only for the consumer, but the small business person as well, is super important. So that's why we think the financial literacy should be part of the curriculum that comes out of out of Washington into the school system.
But you're also suggesting that financial literacy can be a strategy that persons who are working within communities can be involved with, and that providing greater levels of financial literacy can raise the financial IQ of individuals to understand how the system works and to understand how they can improve the economic conditions for themselves and their family. I want to stay. Okay, go ahead. Yes.
I was talking to someone early in the week, and if we have financial literacy in the school, just think in the next generation or two, we could close that wealth gap. Because if you know something about finance, you would know how to invest your 401k. In most of our communities, people don't know what a 401k is. And when they get it, they don't know what to do with it.
I see you. Dr. Hildreth, were you going to say something?
No.
No. Okay. All right. I want to go to Dr. Professor Marcella Alsan again. You are. I want you to put on your hat as an economist, because we are talking about economic issues and economic challenges that communities of color face. And there's research that shows that the COVID-19 pandemic has not only had a disproportionate impact in terms of loss of life, but it has had a disproportionate economic impact. I was looking at data from a Kaiser Family Foundation study that showed that over 50% of about 50% of African Americans and Latinos reported that they had some economic challenge in terms of COVID-19. So what would be some of your recommendations, practical recommendations for dealing with communities that were already in terms of wealth? For every dollar of wealth white households have, according to the Federal Reserve Board, African-American households have 10 pennies. Latino households have 12 pennies. So that's where they were before the pandemic. Now the pandemic has worsened things. What are the recommendations you would think of for communities of color along economic lines?
Yeah, thank you for that question. And just going back to, I want to mention a couple of resources for people. So Kaiser Family Foundation is a great resource that Professor Williams just mentioned. United States of Care is a great resource as we pivot from describing the problem to describing some of the policy solutions to the problem. And going back to what we were talking about with Dr. Hildreth about how we can get policy changes with regards to the pipeline, and then this will interdigitate with the economic pain. You know, obviously K through 12 education is crucial. Financial literacy in schools, as Mr. McDonald Jr. said, is crucial. But also having people at that leadership table that can look at those applications and also look at the lives and the struggles and the everyday weathering that occurs for people that don't look like the typical mold of, let's say, a medical school president or a professor at Harvard or a bank president or a community leader. And having a variety, a diversity of thought and opinion, looking at applications and deciding on policy is also crucial to solving the issues that we're facing, the entrenched inequality that has been there and has only been highlighted by this pandemic. Now let's look at policy. So I think on the policy side, we can just think about the Great Recession. We saw erosion of wealth for African American and Hispanic communities and Native American communities that were orders of magnitude larger than white communities. And they were already starting off at a relative disadvantage. And it took over almost a decade. People were just scraping back to where they had been before the Great Recession when the pandemic hit. And so some of the injection of funds, this quote unquote stimulus, did help. You know, the moratorium on evictions and some of the increases in unemployment, et cetera, helped. But that help is quickly going away, and it's really opening the floodgates now with potential. There's a fear that there will be a tsunami of evictions coming up, and that, you know, many children have lost maybe a year or more of schooling due to the pandemic. And women, how are women who have been taken out of the workforce, how will they be able to get back? So I think it's a variety of programs. I think the American Families Plan that is being put on the table to provide for universal preschool and to allow women to get back to work, that is going to be a helpful thing. Serious discussions that are being now had to actually allow for healthcare to be available to everyone, whether or not they have a job. Serious discussions about expanding Medicaid. I mean, it's absolutely crucial that we have the private sector involved, but to address some of these very large, very long-standing inequities, we really do need federal dollars. We need our budget, our government budget, to reflect the needs on the ground. And so those are just a couple of, you know, the expansion of the ACA, which I think some would even see to go even farther, to have a really robust standalone public option for people to have, as well as increasing preschool, and then allowing that to be free for mothers to go back to work, and also directing loans and strengthening opportunity zones so that we can allow businesses of color owned by people of color to flourish, and making credit available to them, to try and redress the fact that for so long they were denied credit, and you know, that's some of the solution that Mr. McDonald, having a Black-owned bank, this gap that he's been filling. So that's just part of it. But we really need to learn the lessons from the Great Recession and try and build back wealth as quickly as possible, even to the unequal place it was before. We have a lot of work to do.
Thank you so much. Now, I've been told that audience question and answer will begin in 3 minutes. So before that 3 minutes hits, I want to go back to Dr. Hildreth, because I wanted to talk to you. You are an immunologist. You are at the forefront of fighting COVID-19. And there have been challenges of the inequities in COVID-19, but many are concerned about the vaccine hesitancy as well within our populations. What would be your recommendations? What do we need to do to restore our populations and get them utilizing all of the resources that are there to help? I think you are muted. Okay,
I'm sorry.
good. Yes.
I'm sorry. I was saying that I think one of the most important things is that we find and engage trusted messengers. We got to have people engaging in these conversations that the communities trust. When I talk about this, I always acknowledge that Black and brown people have every reason to be hesitant, to be concerned about the vaccines. Most people refer to Tuskegee, but there's the involuntary sterilization of Black and brown women. There are atrocities that go all the way back to 1619. So we know we have reason for this, but the vaccine is far less of a concern than COVID-19 is for our communities. I mean, this virus is agnostic to your race, your political affiliation, your religion. But the bottom line is that if you have an underlying condition, it will make you very sick and kill you. And that means that Black and brown people in this country, we need the vaccine the most, more than anyone else. So we got to find ways to let people know, to answer their questions. They're legitimate questions. We just have to answer them fully with the right messengers. And I think we'll get this done. So that's the approach that we've been taking.
Wonderful. And so we need to affirm that asking questions is not a problem, but let's try to get them trusted sources of information to, in fact, deal with their questions.
Yes.
Do I have, I think Mahalia is joining us now, and you're going to share with us the questions?
Yes, I will, sir. Thank you all so much for this fantastic panel thus far. I think that I speak for the entire audience when I say it's been incredible to listen to you all. A perfect segue into the last topic we were discussing. Our audience would love to know from all of you, how can we address the history of medical distrust among people of color, especially African Americans, and especially in this moment of a global pandemic? Because as you said earlier from this panel, we're hoping not just to address the problems, but also the solutions. So how do you see us all moving to the next step?
Can I flip that question around? Because I do feel like some of it is, how can the healthcare system be more trustworthy? How can the healthcare system actually be worthy of the trust of individuals that have so often been abused? I want to actually say to many of the people that are out there right now who might be on social media, your power is incredible. Just as one example, there was recently a podcast that actually was produced by a major medical outlet, and it said, how can, and Dr. Williams and Dr. Hildreth probably have a lot more insight on this than I do, but I just want to provide it as an example of activism and something like powerful that people have been doing. That said, the podcast said, how can there be, how can there be racism in medicine when no doctor is racist? And that was basically on the, put forward by, again, this really high profile medical journal. And it was finally taken down because of the outpouring that, regular everyday people have said, this is absolutely unacceptable. And so I think the real question that, although I have documented in prior research how the Tuskegee event, it was a watershed event, and it did increase medical mistrust. There is contemporaneous racism, as we know today. And some of these challenges are on the co-pays and the additional hassle costs and the transportation costs. That's structural racism. And then there's the feeling of indignity and the not being heard and the not getting serviced, and the wait times and all of that also goes on as well. So those are two parts that I think we have to work on. I have a little bit more to say on vaccinating messengers, but I know that there's a lot of wisdom on this panel, so I want to stop there.
I'm sure Dr. Hildreth wants to say something, but before you do, let me just add something that's really important. While the history is important, and I agree, and I think it was reflected in Dr. Marcella's answer, it's not just the history that is shaping Black people's reluctance. It's what's happening every day in social institutions, in accessing medical care. So it's not just the history. The history is being confirmed and being repeated in the reality of people's lives. So we find in my own work with the everyday discrimination scale, just 9 items that don't capture big aspects of discrimination, but treated with less courtesy and respect than others, receiving poorer service than others at restaurants or stores, people acting as if you are not smart if they're afraid of you. Those little indignities, people who score high on them, when their physician requires them to follow up on a test, they're less likely to do it because the whole experience has been dehumanizing. So why should we trust you with what you are offering me? So while the history is important and it gives us some context, the history continues and is part of the lived experiences of our population. So I agree with you about we have to turn the question around and also say, how can our institutions function differently and really treat every patient with dignity and respect? And it is possible, but we need to make a firm commitment to do it. Dr. Hildreth, I'm sure you want to say something in response to this question.
Well, Dr. Williams, I was going to say what you said, that the history is important, but things that are happening today affirm the fact that if you're a brown or Black, you're going to be differently engaged by the healthcare system. It's just a fact. I was just speaking earlier about the fact that there are studies to show that you take 2 actors, we use actors to teach our medical students clinical skills. 1 Black, 1 white, same job, same pay, same education level, same neighborhood they live in. You put them in front of physicians. The white patient is much more likely to get the most up-to-date comprehensive treatment plan than the Black person, regardless of everything else being identical. So it's a real phenomenon. And what we have to do is people have to be made aware that they have an amount of power they can exert when interacting with the providers, right? Because your health is your most precious asset. With all due respect to my colleague, Mr. McDonald, the financial, things are really important, but your health is your most important and precious asset. So the person that you're engaging with, you're entrusting them with your most precious asset. So we have to speak out about not being treated with dignity, not being taken seriously. I mean, my mother, God rest her soul, complained to me bitterly about going to the doctor in the South. I'm from Arkansas. The doctor never laid hands on her, never talked to her directly, was always focused on the screen in front of him and not engaging. So if you're having an interaction like that, of course you don't trust the person, right? How can you? So we've got to find a way to make sure that people understand they have a certain amount of power in this. And I totally agree with my colleague, Dr. Marcella, that we have to use that power and speak out about it and affect some changes, because it's just not serving us well. And I'm part of that system and I see it from the inside. And we're trying to make sure we train our students to recognize that every person sitting in front of you needs to be treated exactly the same, right? You have to connect with them and treat them exactly the same. And when we admit our students to medical school, they go through interviews. We ask them lots of questions, but the last question is the most important question. And it's not a question to the student. It's a question we ask ourselves. Will we want that person taking care of our mother, our child, or our loved one? And if the answer is no, they don't get in. It doesn't matter what their MCAT score is, what their GPA is. The answer to that last question is no, they just don't get in. Wow. So, sorry, I'm
yes,
going.
No. This is wonderful. Mahalia, can I bring in Allie Young on this, because I want you to talk a little bit about the Native American situation when we talk about mistrust as well, because on the Native American population in the United States at one level is unique, and that is it's the only community for which the federal government has a legal responsibility to provide health care. It's the Indian Health Service. On the other hand, if you look at the budget of the Indian Health Service, it is funded per person less than even the Medicaid program, which is funded woefully poorly. So can you talk a little bit about the Native American perspective on this?
Yes. Thank you for bringing me in. I was going to chime in. Yeah. So right now, we actually, Navajo Nation could be the first community to reach herd immunity as far as the vaccine, which is incredible. And it's also across the country in other tribal nations, the vaccine rollout has been super successful. But that's what I've been communicating to a lot of folks, that if there's a community that to distrust the federal government, it's the Native American community. When you think about the broken treaties, we are guaranteed health care, but it is pretty poor health care. And the broken infrastructure within that system is, it's something that needs work. And I think because of this pandemic, we have solutions, and we can't wait to be in communication with the current administration about these solutions. But Indian Health Service has been chronically underfunded for far too long. And but what's incredible about the vaccine rollout is that the current administration gave the vaccines, the supplies that Navajo Nation in particular needed. And left it to us to implement on our own. And look at what's happened. It's been super successful. And I think that speaks to tribal sovereignty. That's the way the relationship should be. Give us the adequate resources and funding that we need in our communities, and leave it to us to implement on our own. with community organizers, with those physicians who've worked in the nation for 20 plus years and have built relationships with our community members, our elders. And that's exactly what I've seen throughout these last, since December is when the vaccine hit the Navajo Nation. And I've seen amazing vaccination events throughout the nation where community members are coming together, volunteering on Saturday mornings, and getting all of our people vaccinated. And right now I think we're over 75% of our population, which is around 175,000 people in a 27,000 square mile reservation. And we're excited because now it's the 12 and up who are being vaccinated. And I think that vaccination rate is just going to keep increasing.
Wonderful. Mahalia, let me go back to you with questions.
Truly incredible answers from the panel. Thank you all so much for speaking to that last point. Now, I have one more question that is also for the wider panel. We've spoken a lot today already about some of the environmental factors that can play a role in providing healthcare, especially in marginalized communities. But we were wondering if you could speak specifically to the environmental hazards that plague low-income communities, rural communities, and communities of color, and how we can help mitigate health outcomes caused by living in these areas.
Who would like to be first on the panel? I have thoughts, but let someone else speak. Well, let me begin with one example, and then others can chime in. There was a study done by some of my colleagues at the Harvard Chan School that looked at the relationship between living in a community that's high on air pollution and the severity of COVID-19 and mortality from COVID-19. And what the study found that across the United States, in areas of high exposure to air pollution at a neighborhood level, people who reside in those areas, if they got COVID-19, it was more likely to be severe. And if they got severe COVID-19, they were more likely to die. So they documented that exposure to air pollution is a risk factor that predicts poorer outcomes from COVID-19. And who lives across America? Who lives in areas of high air pollution? Communities of color and poor individuals more generally, low-income individuals more generally live in those communities. And so while we think of, and I do research on the psychosocial stressors that matter for health, we should not neglect the physical, chemical exposures that our communities are disproportionately exposed to and that also have adverse consequences for their health.
I can add on. I mean, obviously, Professor Williams is certainly the expert on, but I mean, I really feel like this is an opportunity to rethink our social contract, because for, you know, when actually I studied the rollout of the Massachusetts sewerage system, and actually when a lot of this infrastructure was laid down was prior to a broad shared understanding of the germ theory, if you can believe it, like the mid 1800s, the early 1900s, when it was thought that people got disease from miasma. And the reason why in the Boston area we have a sewage system, the history of ours anyway, is that all of the feces and all of the effluent would flow downstream to the Boston Harbor, and a lot of wealthy people lived on the land around the Boston Harbor. And so it was this feeling like there was no antibiotic, there was no oral rehydration salt that could quickly fix the problem. And so they had to make these large-scale infrastructure investments across the board. And some of the infrastructure we have to deal with water and sewerage, look at Flint, Michigan, look at all the lead pipes we still have. This infrastructure is extremely old and dangerous. And until we just say, you know, again, going back to Dr. Hildreth's point, a life is a life, all lives matter, until we really, you know, it's not about the money. Look, we just had $2 trillion, $3 trillion go out the door. It's not about the money, it's about the values. We have the money to do this. And so that, I guess, is my global response to that question. And we know the health risks from polluted air, and how many more papers can we write about what it does to babies and pregnant mothers and cardiovascular risk and interacting with respiratory viruses. I mean, we've known clean water is important, for a very long time now. So it's not about the science, not about the money. I think it's about the will.
Yeah, I think, just to add from the financial industry's point of view, we have an area called Cancer Alley that it's been documented that a lot of individuals are affected with healthcare issues as a result of that. So looking at the collaboration and thinking about policy, et cetera, how do we consolidate and combine the efforts to have funding to relocate these individuals? Because a lot of these individuals, perhaps they own properties, they've paid for these properties for a long period of time, and there should be something to help them relocate to a safer area. We had a number of other areas in the community with environmental issues. And I think the biggest problem is how to help transfer the equity that was built up in their asset to another asset that would eliminate the health hazard. So when I talk in terms about the collaborative, including the financial industry, we can come up with a number of issues and a number of items that go hand in hand. And so a further collaboration on an ongoing basis with the financial industry, we can perhaps offset, come up with some ideas as to how to help in this disparity.
Thank you so much.
I'll just add to that. So, I mean, I think it comes down to people over profit. And that's what we've been saying as Indigenous communities fighting this environmental justice fight that we're in, fighting climate change. And we've seen the impacts and the effects of environmental destruction, especially in Native communities. And I've been telling folks, look at a map of the Navajo Nation, where historically there was uranium mining that took place in certain regions of the nation. And in those regions, those were the hot spots of COVID-19 this past year. And that's because a lot of those underlying health conditions that our folks, our elders who worked in uranium mines, who drank contaminated water and now suffer from lung diseases and lung, respiratory issues. And they're the ones that were impacted and their lives were taken. And I think we need to pay attention to that. And as far as, relocation, I think just bringing in the Indigenous perspective, we've been relocated many times, our families, for these extractive industries to come in and build these uranium mines and coal mines. And we, frankly, in reservations, we don't want to be relocated. We don't want to leave our homelands. So I think, there are still abandoned uranium mines and coal mines in tribal nations that needs to be cleaned up. Why hasn't that happened? And so, I think we need to come up definitely with solutions, and it comes down to, humanity. And without Mother Earth, there is no humanity. And so we need to continue this fight to save Mother Earth.
Yes.
Thank you. Mahalia, I'm sure you have more questions for us.
I sure do. The audience can't get enough of you guys. And thank you so much for your powerful and very important perspectives thus far. So now I have a few questions for specific panel members. First off, Marcella, earlier in the panel, you mentioned getting a diversity of perspectives in the room to determine whether to extend a line of credit to someone. But how has tech impacted decision making for the better or for the worse in terms of making these choices?
That's a great question. As many of you know, there's been a huge surge in the use of telemedicine since the pandemic began. And there's been a loosening on the policy side from the CMS, allowing physicians now to be reimbursed. There's a question about whether medical license could now be used permanently across different boundaries. So there's been a lot of rethinking of all of the licensure restrictions that we've had on physicians and health professionals more broadly, enabling potentially a huge increase in access for individuals. I mean, transportation is a huge issue for lots of communities still, not just rural communities, but it's oftentimes hard to find a public transportation to a clinic. And then, there's a lot of times that people don't have vehicles, don't have licenses, they get their licenses taken away. How are they going to get to the doctor? Don't have glasses or prescriptions that allow them to drive. So it's a possibility that telemedicine could actually help reduce health inequality and close those gaps. But the jury is still out, because obviously we have to see if this reimbursement still continues so that telemedicine is kind of put on an equal footing with physical medicine. We also have to make sure that Wi-Fi is extending. So some of the infrastructure bill allowed Wi-Fi. I mean, many on social media probably saw those really concerning pictures of little children of color trying to get Wi-Fi outside of a fast food restaurant during the pandemic because they didn't have access to Wi-Fi. So it's only going to increase inequality if some people have access to Wi-Fi and some people don't. And then let's think about the platform and how user-friendly it is and what sorts of perspectives are included. I mean, on the one hand, going virtual can strip away some of the indignities of getting to a triage nurse who doesn't really think that you have any pain, or some of the structure that you have to go through to try and actually get care, and just calling in from your phone or calling in from your laptop. So in some ways you could probably have indignity avoidance through telehealth. But who's going to be on the other side of the screen, and what is the app going to look like? And will there be various ways to call symptoms? And I don't think, as an economist, I don't think it's a perfect substitute for actually having another place where you can go to actually seek care and get a physical and get the tests you need, et cetera. So I think the jury is still out. It's exciting. It could be a huge increase in access for individuals if it's funded, if it has the diversity at the top of tech, which we certainly don't have, and if there's broadband available to all populations.
Okay, Mahalia, you have another question?
I sure do. Thank you so much for answering that last one, Marcella. And on to the next question from the audience. Turning back to Allie, you spoke earlier in the panel about how one of the main issues for Indigenous communities is ensuring that they aren't made invisible. And you spoke some also about how some Indigenous youth have reacted to the pandemic, turning to social media, etc. But I was wondering if you could speak a bit more to how, if you could speak a bit more to where there are opportunities for leadership to effectively advocate for Indigenous communities and help ensure that they are not made invisible.
Absolutely. Thank you for that question. Yeah, I encourage you to go on Twitter and type in #NativeTwitter, and that's where you'll find a lot of Indigenous scholars, educators, activists. And yeah, we're out there, and because of that invisibility on mainstream platforms, we've created our own platforms, and that's through social media, through Twitter, Instagram, and I encourage you to follow and look up Illuminative, Native Organizers Alliance, Advanced Native Political Leadership, NDN Collective, so NDN Collective, And then my own program that's within a nonprofit called Harness. It's called Protect the Sacred on Twitter. It's at protect_sacred. And so, yeah, we're out there. And I think we're easy to find and easy to communicate with. Sending us DMs or tweets. Our emails are often in our bios. So I encourage you to reach out to these organizations who are doing amazing work about amplifying and elevating Indigenous community storytellers and our voices. And we have toolkits as well. And that's an access point, and we welcome you.
Fantastic. Thank you so much for answering that question, Allie. Another question to this time for Mr. McDonald. Our audience would like to know, how can executives demonstrate leadership to provide equitable opportunities for minority communities and leverage their resources more effectively for social justice?
The sensitivity to executive leadership to put things in a different fashion going forward, and helping increase the ability to increase one's wealth. For example, I serve on the board of a hospital and a medical group, and we recently brought in, because of the Black Lives Matter, someone to take total inventory of the entire hospital, the purchasing, the employment, and the upward mobility and training, et cetera. And so that's going to have a serious change economically within the hospital and its staff and its employees. I think from an executive level, et cetera, we spoke earlier about the physicians and how the physicians react to the patient. I think making sure that the quality surveys in these hospitals ask the right questions on the quality of treatment. We have certainly done that within the hospital system where I serve on the board. So executives, not only from the financial industry, but executives throughout all walks of life can push for some of these health disparity issues in a lot of different ways.
More questions, Mahalia?
Sure do. And again, incredible. Thank you so much for your answer. As for our next question, as we're getting to the end of this panel, our audience would love to know, what have you learned from each other? You've all come from a variety of backgrounds and different experiences. So it'd be great to hear from, what you've heard so far from each other, what you're all taking away, and how it might affect your work.
That's a real good question.
Yeah.
I would say, as someone who works within the field of inequities in health, it's been a great panel for me, just listening to my colleagues and listening to the insights that are taking place, learning about what's happening to build success stories and in Native American communities. No, I didn't know about the success of the vaccine campaign in Navajo Nation, and that putting it in the hands of those who are feeling the pain. They know their communities. They know what to do. They can. What if we took that as a model of addressing vaccine hesitancy in the United States? I think learning from all of my colleagues, Dr. Hildreth, who is someone I've known and admire him and his leadership, but really learning about what his university is doing and the huge impact it's having on training dentists. Dental care is an area where Americans in general are not getting the kind of care they should have, and all of those things are worse for populations of color. Meeting Alden and learning about the work that he's doing and the phenomenal success he's had with a bank. So I would say, and of course, my colleague, I'm meeting her for the first time, Marcella, but I know her work and I use her work, and it is such striking evidence of what can be done. The question is, how do we get the word out and build the empathy that is needed to get more people to the table and feel these things are unacceptable in our country, and we're going to work for to solve them. That's my response.
I would like to add something to the comment. I've learned that a lot of the issues that we deal with every day in the health disparity area, it's been known for a while. And this panel allows me the opportunity to validate what we know and what we deal with every day. And the collaboration, I'm learning that perhaps this is a mechanism for all sorts of industries to come together and to resolve the issues that we have. So we haven't talked about mental illness, depression, etc. So when this pandemic is over, we have it whipped with the COVID-19 testing, you still have a lot of families that have a high depression level. And so what are we doing to do that? And again, to consolidate the thought process, we deal with people who are having financial issues. And when we sit down with them and solve those financial issues, we see the families coming together because it eliminates depression that exists. So there are a number of things that I've learned and would like to see this program bring in the financial industry. I think we could add a lot because my colleagues, we all are involved in community issues, whether or not it's sitting on the board of a hospital, whether it's dealing with clinics, whether it's dealing with schools. But a lot of these issues comes before us in the world of finance. And so there are a number of things I think we can all come together and learn from and perhaps produce some solutions.
I'll jump in. I think that, you know, what I've learned is that we're all aligned in our goals for our respective communities. And I'm looking forward to staying in touch and connecting down the road, because I'm a firm believer in that we need to kind of come out of our silos and cross collaborate. And when we show up as allies to each other's communities, we're a powerful force that they cannot stop. And I think that coming off of the 2020 elections, we all showed up in our respective communities. The community organizing was incredible to see. And I think the next step is leaning into collective organizing. And I look forward to working with all of you. Thank you.
Anyone else? Yes, Dr. Hildreth, I think you're muted.
Sorry, I'm trying to keep the train from being too much of a nuisance. There's a train going by. I would just echo what Allie said, which is that I'm very encouraged that we can approach these problems from many different perspectives. And if we all work together, we're probably going to be much more impactful than working alone. I'm also struck by the fact that as an undercurrent of healthcare inequities and lots of other things, we just got to find a way to deal with structural racism. It runs through everything. And I think working together is one way that we can find some solution to that as well. So I'm just excited to be part of this really important conversation. So thank you again to the organizers for inviting me.
Just adding my 2 cents, I want to thank you, and Professor Williams, thank you for just moderating so amazingly well. I have learned, I mean, honestly, I've been extremely impressed with Allie to learn what she's gone through, what she suffered in her personal life with her brother's passing, and to see her turn that around is incredible. From Mr. McDonald, the importance of financial literacy. It's not, you know, it's not at the top of the conversation, but it certainly seems important. And then from Dr. Hildreth, you know, the success of Meharry, and I've actually worked, co-authored with a Meharry student. The success and the empower that they feel is because they are able to be themselves. And what a powerful lesson that holds for all of us. And all of you out there. So honored and invigorated, honestly, from the conversation. Thank you.
Mahalia, any more questions for us? Or
yes, I was going to say thank you so much for answering all of these questions from the panel. That's actually all the questions we have left from the audience, you know, other than the waves of praise that they are sending all your way. So I turn it over to you, Dr. Williams, to close us out.
all right, thank you very much. I think we've got 2 minutes. Any final, if you had one recommendation to make that you could make in 1 or 2 sentences, every panelist, what would you tell the audience are the things they should be doing next? Allie, I think you're the youngest here. We're going to start with you. What would you say? What would be your 2 sentences to everyone?
Shout where this are in. We're here. We want to engage with you all for that. We're gonna.
Something is wrong with your speaker. It's not working well, Allie. We're not hearing you clearly. I'm sorry. If you can put it in the private chat, I'll read it. Mr. McDonald, what would be your 2 words of recommendation if you had to leave one thing with the audience? You're muted. Okay, you're
muted. 2 things that I would like to leave with the audience. Let's all come together and develop some achievable goals. That's number 1. Let's work for consensus and coordination in achieving these goals. And the third piece and last piece, please bring the financial industry into the mix, because a lot of medical disparities is a result of financial issues.
Wonderful. Dr. Marcella, we're down to seconds now. I think you're muted also.
Continue the activism around voting and protecting the right to vote.
Yes.
Thank you so much. And Dr. Hildreth.
I was going to say what Marcella said. Have your voice heard, and the best way to have your voice heard is to vote.
I agree. A great panel. It's been an honor to be with all of you, and to the audience. Let's get engaged. Let's make a difference. Let's be a tiny ripple of hope, and together we can build a current that can sweep down the mightiest walls of oppression and resistance. Those are the words of Robert Kennedy, but they resonate with me, that together we can make a difference.